I'd like to invite Dr. Vikash Agrawal for ESC guideline update for peripheral vascular disease. He doesn't need introduction. He's my colleague and friend, Professor Cardiology, IMS BHU. Please.
So good evening. First of all, I would like to congratulate Dr. Alok for conducting this conference for past so many years so successfully with a great academic topics and great learning that happens here. So congratulations again to him. I'll be talking about 2024 ESC guideline update on peripheral arterial disease. And these are pretty exhaustive documents, and these include peripheral arterial disease as well as aortic diseases, but I would restrict myself to peripheral arterial diseases. And starting with the recently published guidelines, the ESC guidelines, this is the central illustration that they proposed, and they say that peripheral arterial disease is underdiagnosed and a very common entity that is missed a lot of times. So for the diagnosis and treatment, they propose a holistic multidisciplinary peripheral arterial and aortic disease approach, and this approach includes all spheres of medicine with nephrologist, cardiologist, cardiothoracic surgeon, anesthesiologist, and a holistic multidisciplinary approach is what they recommend. So the guidelines have a class 1 recommendation that you should adopt a comprehensive approach that addresses the entirety of the arterial circulation once you are managing peripheral arterial diseases. These are the clinical subsets of peripheral arterial disease. Patient could be asymptomatic, or it could be a chronic symptomatic patient with typical symptoms of claudication or exertional leg symptoms. And then there are more severe subsets that are included in peripheral arterial disease, which we call as the CLTI, the chronic limb threatening ischemia, and the ALI, that is the acute limb ischemia. History and physical examination is typical. I'm not going into the details. Patient generally presents with claudication or other non-joint related exertional lower extremity symptoms, or symptoms of impaired walking. Then they can have ischemic rest pain, history of a non-healing or slow-healing ulcer, or extremity wound, and erectile dysfunction. The signs are basically abnormal lower extremity pulsations, vascular bruit, non-healing lower extremity wound, lower extremity gangrene, or it could have other physical findings suggestive of ischemia like asymmetric skin changes like hair, asymmetric hair growth, nail bed changes, and calf muscle atrophy. This is the most important thing. How do you diagnose and screen patients for peripheral arterial diseases? And the most important index is the ankle brachial index. And how do you calculate the ankle brachial index? You apply a cuff at the upper and the lower limbs, and you basically look for the higher systolic ankle pressure of the target leg. Basically, it could be the posterior tibial or the dorsalis pedis artery, and this is divided by the higher systolic brachial pressure irrespective of the target leg. And the values of ankle brachial index could range from less than 0.9 is considered to be a abnormally low ankle brachial index and is diagnostic of peripheral arterial disease. More than 1.4 is also abnormal, and this is usually found in old-aged individuals who have a calcific or a sclerotic artery, where you could find an abnormally high ankle brachial index. 1 to 1.4 is considered to be normal. And somebody who has a more than 1.4 ankle brachial index, you could go for the toe brachial index. Toe brachial index basically is the toe pressure of the target leg divided by the higher systolic brachial pressure irrespective of the target leg. And toe pressure is basically seen by the plethysmography probe on the distal pulp of the first or second toe. That is how you calculate the toe brachial index. And a value less than 0.7 is an abnormally low toe brachial index and indicative of peripheral arterial disease. Then the third criteria is hemodynamic criteria of CLTI, which is very important. The three parameters here are ankle pressure of less than 50, toe pressure of less than 30, and one of the important parameters here that is looked after is the transcutaneous oxygen partial pressure, that's TCPO2, and the normal TCPO2 is around 70 to 80 millimeters of mercury. If it is less than 30, then it indicates that there is significant CLTI, and less than 30, basically TCPO2 indicates tissue viability or whether the skin perfusion is maintained in patients of CLTI. So a value of less than 30 is basically diagnostic of CLTI. So the recommendation in the guidelines are basically class 1 for measuring of ankle brachial index as a diagnostic criteria with a value of less than 0.9, and for patients who have more than 1.4, additional methods like toe pressure or toe brachial index or Doppler waveform analysis are recommended. Coming to the clinical presentation, this has been classified by two classification systems, the Rutherford and the Fontaine classification, and basically all these two classification systems classify these patients of PAD into asymptomatic PAD, symptomatic effort-related PAD, or chronic limb-threatening ischemia, and these according to the severity, how severe the peripheral arterial disease is, from category 0 to 6. And in Fontaine classification from stage 1 to 4, depending upon the different severity of peripheral arterial disease. So this is how we clinically classify peripheral arterial diseases. Once you are having a peripheral arterial diseases, there is a cardiovascular risk that is also involved, and it has been shown that patients of PAD have a 4 to 5 times increased risk of cardiovascular events. So once you are managing peripheral arterial disease, the central therapeutic aims of management are to reduce the risk of MACE, the cardiac MACE that is involved with peripheral arterial disease, to reduce the risk of major adverse limb events, which includes amputation, chronic or acute lower limb ischemia or lower limb revascularization, and also to improve the quality of life. So these are the three central therapeutic aims for management of PAD. And cardiovascular risk modification and healthy lifestyle interventions are a very important part in the guidelines for managing of PAD. Strict blood pressure control, control of lipids, optimal glucose control, reducing the risk of atherothrombosis by different medications is recommended. And the targets, very stringent targets, are set in the guidelines for lipid and blood pressure targets. And also smoking cessation, maintaining a good lifestyle are all important in the management of PAD. Then there are recommendations for antithrombotic treatment for patients who have a chronic symptomatic peripheral arterial disease, and patient with any once a patient has chronic symptomatic PAD, and you look at the risk level that is involved, and patients who have non-high risk limb presentation or high risk comorbidity, single antiplatelet therapy is enough in these patients. But patients who have high risk presentation and high risk comorbidities, aspirin plus 2.5 milligram rivaroxaban is a class 2A indication. And patients who require anticoagulation, single oral anticoagulant monotherapy could be recommended in these patients. But once a patient has undergone revascularization, for symptomatic PAD, antiplatelet or antithrombotic therapy here changes, and it depends upon patient whether he requires long-term anticoagulation or not. A patient who requires long-term anticoagulation and does not have a high bleeding risk, single antiplatelet therapy with an oral anticoagulation is recommended for 3 months, followed by oral anticoagulant monotherapy. But patients having high bleeding risk, only oral anticoagulant monotherapy is recommended. For patients who do not require long-term anticoagulation and the bleeding risk do not require long-term anticoagulation and the bleeding risk is not high, aspirin plus 2.5 milligram rivaroxaban for 1 month, followed by aspirin and 2.5 milligram rivaroxaban BID is recommended. For patients who have high bleeding risk, dual antiplatelet therapy with aspirin and clopidogrel for 3 months, followed by single antiplatelet therapy with either aspirin or clopidogrel is recommended. So this is after revascularization of a peripheral arterial disease. A lot of stress in these guidelines has been given on exercise training in peripheral arterial disease, and this has become a class 1 recommendation in the ESC guidelines, and it has been proposed as a modality of treatment in peripheral arterial disease. So they recommend that supervised exercise training is very important in patients who are symptomatic for peripheral arterial disease, and they recommend at least 3 times per week exercise training, whether it could be supervised hospital-based exercise training or supervised home-based exercise training, and the session duration of at least 30 minutes, programs duration of 12 weeks. Low to moderate intensity exercise is recommended, and the benefits they have shown that there are various studies to show that exercise training decreases symptoms, increases quality of life, increases walking performance, and also functional status. And there are the potential mechanisms they have proposed are myocardial arteriogenesis, endothelial function improvement, and myofiber size and inflammation. So exercise training has become very important in these guidelines. So this is just a gist about the diagnostic algorithm that they propose. Suspicion of peripheral arterial disease, you do a clinical assessment with physical examination, and then you go for a walking impairment assessment. This could be due through by the use of a questionnaire or a treadmill, and functional assessment by a 6-minute walk test or SPPB. And once you do a clinical and functional assessment, you go for hemodynamic and vascular assessment with an ankle brachial index, toe pressure, TCPO2, and Doppler ultrasound. And one of the things they recommend in patients who have severe disease is wound assessment. Somebody who has a wound, this classification is by the wound assessment score, which I am going to tell in the next slide. And then you come to a diagnosis of peripheral arterial diseases. And once a patient has typical symptoms of peripheral arterial diseases, then you go to diagnose whether it is symptomatic PAD or chronic limb-threatening ischemia. Once he has ischemic rest pain or gangrene or a non-healing chronic wound or critical limb perfusion defect, then with the 3 hemodynamic parameters, then the diagnosis of chronic limb-threatening ischemia is there. Then there's an entity called masked PAD, somebody who has PAD but does not have the typical symptoms of peripheral arterial disease, what you label as masked PAD. This is the wound ischemia foot infection classification by the peripheral arterial disease guidelines, and this basically gives an assessment of the risk of amputation these patients have once they have peripheral arterial disease, especially patients of CLTI. The 3 components are WI and foot infection, each having a score of 0 to 3 with different parameters that are taken. And once you take all the scores, you classify these patients into very low risk, medium risk, and high risk for risk of amputation according to this score. So this score helps in classifying these patients for the risk of amputation. Preventive foot care and leg symptom management in patients of PAD. Education is important, foot inspection, then care of ulcers, and all these things are important. And for patients having leg symptoms, cilostazol is one of the drugs that they propose to increase walking distance and reduce symptoms, and it is a class 1 recommendation in the ACC guidelines. They have not commented in the ESC guidelines. But pentoxifylline, they have shown that it has no benefit, so it should not be recommended in patients of peripheral arterial diseases. The treatment algorithm, basically this is a very congested slide, but I just want to highlight that they have divided the treatment algorithm into 2: patients with PAD syndromes without wounds and patients with PAD syndrome with wounds. So somebody who has a PAD without wound and is asymptomatic, only optimal medical therapy is recommended. Somebody who has symptomatic PAD and basically having symptoms after supervised structured based exercise training, that is recommended. Still he is symptomatic, then revascularization could be considered. In patients with CLTI with optimal medical therapy, revascularization is recommended. For patients with wounds, asymptomatic, healing should be allowed to happen in these patients, but revascularization is considered in patients with symptomatic and patients who do not have healing of the wounds, here revascularization. And for CLTI, early revascularization is recommended. The recommendations for interventional treatment, patients with PAD, revascularization is only recommended after 3 months of OMT and exercise therapy. And for the mechanism of revascularization in patients with femoral popliteal disease lesions, drug-eluting treatment should be considered as the first choice therapy, which is a class 2A indication. For patients with iliac lesions, stenting in external iliac arteries or primary stenting in common iliac arteries could be considered. And for femoral-popliteal lesions, if revascularization is indicated, endovascular therapy should be considered. So for femoral-popliteal lesions, it's basically endovascular therapy, which is given more preference to as regards to surgery. If a person undergoes surgery, autologous vein, that is great saphenous vein, is available, and patient has low surgical risk, these patients can undergo an open surgical approach for revascularization. For chronic limb-threatening ischemia, it is recommended to perform revascularization as soon as possible with the use of autologous vein as a conduit for inguinal bypass surgery. And for multi-level vascular disease, it is recommended to eliminate inflow obstructions when treating downstream lesions. So interventional treatment is recommended for CLTI. The last aspect is acute limb ischemia. These are acute patients who present with severe limb ischemia, and this is how to classify these patients. This is basically classified into by looking at 5 parameters, that is sensory loss, motor deficit, arterial Doppler signal, venous Doppler signal, and capillary refill. And once you look at all these parameters, you grade these patients from a grade 1, grade 2A, grade 2B, and 3. Grade 1 is viable, grade 2 is marginally threatened, grade 2B is immediately threatened, and grade 3 is irreversible. And the management part that they recommend is patients who are grade 1, that is viable, urgent revascularization and anticoagulation is recommended. For 2A and 2B, emergency revascularization and anticoagulation, and for grade 3, irreversible, there only palliative care and primary amputation can be done in these patients. So I'm not going into the carotid artery, or I think I'll just conclude because of the lack of time. So my final conclusions will be that peripheral arterial disease is highly prevalent disease, underdiagnosed and undertreated. Screening and diagnosis is very important in these group of patients to get to know about patients of peripheral arterial disease. Females have a lot of atypical symptoms or could be asymptomatic, what we call as the masked peripheral arterial disease symptoms. And exercise along with pharmacological lifestyle treatment is the first line of management, and high cardiovascular risk is 4 to 5 times in these group of patients, which should be tackled with lifestyle and drug therapy. Thank you.